Hi, everybody. Welcome back, and thank you for joining us for our sixth Kelly Gynecologic Oncology Society webinar. Our survivorship program has been thrilled and to have a series of wonderful speakers who have joined us to talk about a number of key topics. And today we're trying out a new time, a middle of the day luncheon instead of an early evening, bring your drink and appetizers setting. And we're also going to be talking to Dr. Tom Smith, who has not joined us previously, but is one of our palliative medicine experts here at Johns Hopkins and a professor here at the university. And our topic today is going to be finding your quality of life coach. So as we're taking our midday break, we're going to sort of be talking about what is the role of palliative medicine and cancer care, and specifically for women who have GYN cancers, their caregivers, family, and friends. How do you think about palliative medicine? When do you incorporate it? How do you incorporate it? And what are some of the tips and tricks of palliative medicine that if we could spread some knowledge, we would want to spread to people about managing side effects of both treatment and cancer, because both obviously bring a lot of impact to patients and their day-to-day lives as they move through the treatment process and even into survivorship, many of those symptoms that just don't go away and stick with you long-term. So I'm going to let Dr. Smith introduce himself and provide a little bit of who is he, what is his area of expertise, and actually I'm going to put out a surprise question, which I've asked all our speakers, which is what is one non-work fun thing about you? So we've learned about people's pottery and prior sporting events and sort of a getting to know you moment. So Dr. Smith, why don't you introduce yourself some?
I can tell you that the one non-work thing that may be the craziest of all that I do is that until I had lung damage from chemotherapy, I was an ultra marathon runner. So I've done a couple 100-mile runs. I've probably done over 100 marathons. For my 55th birthday, 4 of us ran across the Grand Canyon and back. We just kept saying, hey, it's only one hill. So that's way off the deep end, way off the deep end. I also like to cook, I like to bake, and I like to garden. And luckily our daughter who's now a Gyn-Onc fellow, has acquired those genes. But I'm a medical oncologist. I spent 35 to 40 years doing breast oncology. I still do a little bit, but mostly have moved into hospice and palliative medicine with a particular emphasis on symptom management. So how do you manage chemoneuropathy? How do you manage hot flashes? How do you manage loss of appetite? How can you help your caregivers survive all this? What questions should you be asking your providers, the nurse practitioner or the doctor, during your visits? I also bring the fortunate or unfortunate perspective as a metastatic cancer survivor to this seminar. I'm not under treatment right now, but as many of you know, the phenomena, you're just waiting for the sword of Damocles or the other shoe to drop. So I can sympathize with many of you on that. I actually wanted to show a couple of slides. I can share the screen here and get to the one I want.
Sounds great.
Hold on one second. If I can you see take-home messages?
It is not showing yet.
Not showing yet. Okay. Get back to Zoom and share screen. Let's start with share screen. And then I want to pick this one.
Yes, take home messages, exactly.
Okay, take home messages.
Introduction, I like this, yes.
And some pearls. So this won't take long, but palliative care can help your GYN onc providers take care of you and your family. In fact, our society, the American Society of Clinical Oncology, recommends that anybody with serious illness be co-managed by a palliative care team. And the reasons for that are better symptom management. It's not that your Gyn-Onc people aren't really good at symptom management, but they're often in the OR, they have other work to do, and frankly, if I have 30 to 45 minutes to figure out what your symptoms are and devise a plan that they don't have, it's another set of eyes and ears. And that likely leads to not only longer, but better survival. This is a study that isn't gyn-onc patients, but there is one from Sloan Kettering. These are lung cancer patients. And these patients, basically, half of them got an iPhone like this that popped up their symptoms once a week. And if it was shortness of breath or nausea, you rated, moved it, swiped right or swiped left for a scale of 0 to 10. And a nurse at Sloan Kettering, or in this case at a cancer center in France, said, oh, that is a big change in somebody's pain. I'm going to call them up, bring them in, and try to fix it. The difference in survival was 10 or 12 people out of 100. That's 10 or 12 people out of 100. It's a huge difference in survival just by fixing symptoms. So message to patients, if you have symptoms, don't suffer in silence. Please call your team and say, look, my nausea is out of control. I'm having diarrhea. I'm having shortness of breath. My legs are swelling up. I hurt. Please call that because it can make the difference between life or death. Here's hot tip for the day. I assume some of you have had hot flashes. I had them for treatment for my prostate cancer. I mentioned I was a runner. I'm a terrible runner, but I am a championship sweater. And when my hot flashes started at 2:45 in the morning, 2 weeks after my first shot of Lupron, every 45 minutes for 8 hours, I would be soaking my underclothes, pajamas, sheets, you name it. I had to keep a couple sets of underwear in the drawer here in my office. Nothing worked for me. A lot of things that work for hot flashes in women don't work in men, but Oxybutynin or Ditropan, which is used for bladder spasms, its other use is to keep people from sweating too much. So within 2 hours of my first dose of 5 milligrams, my hot flashes just stopped cold. That was the first night in months that I'd gotten a decent night's sleep. And as all of you know, if you get a decent night's sleep, the world looks a whole heck of a lot better the next day. So the Mayo Clinic just finished this up. We just published this. This is placebo. This is the number of hot flashes and the severity. And that's what you typically see with placebo. It helps a little bit. But either 2.5 or 5 milligrams drop the hot flash number and severity like a stone. And it works really quickly. This is 1 week. You can see they've already started coming down. Usually you'll see the effect in a day or two. Take home message number 2. So I told you about hot flashes. For chemoneuropathy, take it seriously. In my breast cancer practice, it is the most common therapy ending surprise that we have. And we used to think if you got through the chemo, it would never get worse. But about 20% of the time, it continues to get worse for a couple of months after your chemo. And then you've lost all the opportunity to reduce the dose or fix it. The reason to take it seriously is because your fall risk is doubled. And if you have bad chemoneuropathy at the end of treatment, 50% of those people are going to have bad neuropathy 5 years later. It doesn't go away on its own if it's been there for a year. The things that seem to work, exercise, walking 45 minutes a day, and some TheraBand exercises to make sure your hips stay stable and strong. One of my friends is an oncologist and neurologist in Edinburgh, Scotland, Marie Fallon, had 2 patients come in and say, you know, I started putting menthol cream on my hands and feet, and I'm ready for more chemotherapy. It made it go away. So I like mineral ice, which is 2%. It's cheap. You spread a teaspoon over all the affected areas 2 or 3 times a day. There's absolutely no harm to it that I can see. I'll show you the picture in a second. If you have hot flashes, pain, numbness, if you have painful neuropathy, numbness neuropathy, tingling neuropathy, try duloxetine as your first drug. You start at 20 or 30 milligrams, 20 if you're old like me, 30 if you're not. And you work up to about 60 a day. You give it a 3-week trial. It's not something that you have to try for 6 months to see if it works or not. If it's going to work, it's going to work in 2 or 3 weeks, and then you switch to something else. After that, there's nothing proven in good double-blind randomized controlled trials to work. I've had good success with one of the oldest antidepressants, nortriptyline, and low doses of gabapentin together. And there's something about the synergistic effect of those. It sort of calms down hot flashes. You can try pregabalin, and there are a number of other drugs that work in different classes. But you want to give each one about a 3-week trial, not a 3-month trial. Here's what mineral ice looks like. What people in Scotland use was something called Dermacool. And you can buy it on Amazon.com. It's 1% menthol. It's very expensive compared to mineral ice, which you can get in the back rub section of any CVS or Walgreens or Walmart. It'll cost you about 10 or 12 bucks for a big jar like that. It looks like hair gel. So you take a teaspoon, you put it in your hands, you rub it all over, and you rub it all over your hands, any part that's affected, numb, tingling, and then you take another teaspoon or two and you rub it all over your feet. It's not dramatic. It's not going to take away your pain that first day. It'll send a cooling message along the damaged pathways for about an hour. And in Marie's study, where she had people apply twice a day to the affected areas and the low back, and I'm not even sure that's important, 82% of people had some significant improvement. 82%. So, and nobody got any harm from it. It's inexpensive, works, it's worth a try. And most of you who have peripheral neuropathy will say, well, I have numbness, I've got pain. Why should I have numbness and pain and tingling together? If I have pain, why should I have numbness? Turns out those are all different nerves. Those are your itch nerves and your cold sensitive nerves and your pressure nerves and your heat sensitive nerves. And they're all damaged too, just like the pain nerves. And putting on this Dermacool or menthol mineral ice, the area of hypersensitivity over 6 weeks went from this big down to this big, just the tips of the fingers. And it might even continue after that. People walked better. They didn't catastrophize as much. You wake up in the morning and you put your feet down and they hurt. And you say, darn, this day's gonna suck just like yesterday. And it that symptom puts you right back into your cancer PTSD mind. And what you'd like to do is string a couple of days together where you're not thinking about cancer at all. Have a new normal life. And it helped with sleep. So palliative care, specialized medical care for people with serious illness. It's focused on providing relief from symptoms, pain, and stress, whatever the diagnosis. It doesn't have to be just at the end of life. We see everybody who gets a heart transplant. We see everybody who gets an artificial heart. The goal is to improve quality of life and just think of it as an extra layer of support. So if your gyn-onc person sends you to palliative care, don't say, oh, does that mean I'm gonna die? No, it means they're thinking about you and hopefully going to help you live longer and better by having another set of eyes and ears. So I'm going to stop sharing at this point. That's all I wanted to say.
It's very helpful, and you touched on lots of things, and I want to kind of pull some things out and dissect out some of the things you mentioned. So one is you mentioned family, and in your definition, and who the palliative medicine service is geared towards, and you include family in that list. And so can you expound upon, I think all of us probably think, well, if my loved one who has cancer is doing better, I as the family member am also going to be doing better. But I think you probably mean that in more ways than one. So can you talk about, when you mention family, how do you mean that?
Sure, I can talk from personal experience. I think me having a cancer that came back after surgery, having to deal with radiation and chemo side effects and losing 50% of my lung function at one point. That was bad for me. It was even worse, I think, for my poor spouse, who felt helpless to manage any of this. and she sees me suffering. So then she feels ineffectual at helping me with my suffering. I got profoundly depressed, even suicidal. So another word to the wise out there, if you're feeling depressed and suicidal, please get some help. Suicide rarely helps anything that I can think of. And depression is very common and not often recognized. So if you as a family member see somebody looking really down and in the dumps, no longer taking interest in doing the things that they did, just ask, are you depressed? Or I have a Canadian friend who's a psychiatrist, Harvey Chochinov, who had 167 patients in their palliative care program for cancer patients. And he did a 45-minute trained psychiatric interview. He did the Beck Depression Inventory with 20 questions. And then he asked them, are you depressed? Or I guess in Canadian it'd be, are you depressed, eh? And it turned out that single question, are you depressed? Or have you felt depressed most of the time, is very sensitive and specific for picking up depression. And then people with cancer who have depression get help with medicines and counseling just like any other person. And depression just causes so much suffering, and it's so under-recognized, and it makes your whole family suffer. Our daughter suffered as well, just watching me go through this. In palliative care, we talk about the person with the illness, but we really talk about a family unit with an illness. It impacts everything you do. It impacts the person with the cancer. The poor person who's the caretaker may have to give up work, may have to be spending all their out-of-pocket expenses on parking, co-pays, college tuition funds, you name it. The financial stresses get worse and worse the longer you live. If you have cancer, you are probably stuck in your job forever, because the last thing you want to do is change insurance and muck up your insurance coverage that you have, which is quite common when you switch. So those are just a couple of the things. What I do as a cancer doctor, and we're trying to teach our people to do that, is I look the cancer patient in the eye and say, how are you coping with this illness? This isn't something that you asked for, and it's not something you deserve. How are you coping? And then listen, and then you sort of physically turn to the family member. And one of these days we'll be able to have family members accompany their patients on their visits to the doctor. And you physically turn and say, how are you coping with Aunt Maud being so ill? If you're a patient, if you're a family member, don't be afraid to say, Tom, Dr. Smith, I'm really having some trouble coping with all the stuff that's going on. In fact, I made a list of the top 3 things that are bothering me. Can we discuss those now? I mean, your doctor may roll his or her eyes a little bit, but believe me, that's the best way to enhance communication, is bring in a list of things that bother you. And never, ever be afraid of bringing things up with the doctor or the nurse practitioner. The other thing, as a family member, as a doctor, as a healthcare professional, I can tell you that there's nothing I can bring up, nothing that my doctors can bring up that I haven't thought about at 2 o'clock in the morning myself. Am I going to live? Is this going to come back? If it's come back, what's going to happen to me? Am I going to die in pain? Do I have 3 months, 3 years? What's going to happen to my insurance? Will the Orioles ever have a winning baseball team? There's nothing you can bring up that the cancer patient and his or her family hasn't already thought about at 2 in the morning.
Yeah, I think that's very true. And sort of to continue, you mentioned depression, which is something I wanted to ask about and inquire whether that's incorporated. So you sort of covered that. Anxiety is something that you were just sort of touching on indirectly when you were saying in terms of what people are thinking about. And I think that gets incorporated into a palliative care or a palliative medicine visit? And what are some of the anxiety related tips and tricks you mentioned bringing it up, which I think is the first step, but then what are some of the other tips and tricks that are discussed for management of that anxiety?
We have a couple of set questions that we have on our template that we ask, and mostly they're there to remind us to ask, because, I'll raise my hand. It's hard to have these discussions. You'd much rather concentrate on, hey, your CA 125 is down to 3. That's the best it's been in years. And I really don't want to talk about the rectal pain that you have, or the incontinence, or the fact that you can't sleep because of the hot flashes. I'd rather concentrate on that graph. So we ask, are you bothered by anxiety? And if people say, well, maybe, you can bet they are. If they say, no, I've got the greatest support system in the world, I've got my loving spouse of 45 years, and I've got 3 kids who live nearby, and my minister knows I'm sick, or my rabbi knows I'm sick and comes to visit me, they may not be anxious, but I bet they are. And then you just ask, well, sort of lean in and say, well, what makes you most anxious? And people will tell you. And it's, I'm afraid the cancer is going to come back. Or I'm afraid this chemo, this is my 8th line of chemotherapy for my ovarian cancer. I'm afraid this isn't going to work. And I'm afraid it's not going to work for very long. And then what happens? What are there other options for me? Are there other clinical trials for me? I can't eat. Should I be getting nutrition? Should I see a nutritionist? So there's all sorts of things that people are anxious. We as healthcare providers, we cannot guess what those are. So we have to ask. So you just say, tell me the things that make you the most anxious. And then you could turn physically and look at the family and say, tell me the things that make you most anxious. I had one of my breast cancer patients' husbands ask if he could see me outside the exam room. And he said, I love the fact that my wife is getting a good response to Taxol and Carbo. This before they were generic. And she's getting bevacizumab or Avastin with it, back when that was in vogue. And what he said was, she's doing great. I'm glad that she's responding. But last month, I got bills for $17,000 in chemotherapy alone. And we've already sold our second house. We're selling our second car. I need to know how long she's going to live so that I can do some financial planning. Maybe we should start selling our home now. Those are the sorts of things that come up. Screening for financial toxicity doesn't have to be complicated. We make it a point of saying, are you having trouble paying for your medicines or your medical care? Yeah. I mean, you guys use really expensive drugs. Now, people are getting Nevo and people are getting Pembro and sometimes Ipi along with that. And I mean, you're talking, sometimes $30,000 or $40,000 a month just for the drugs alone. And a 20% copay can exhaust most families on that. So patients often don't bring that up. So we make a point alongside of saying, are you feeling anxious about things? Are you feeling, are you having financial stresses that we should know about?
I think in all the different things we've talked about so far and that you've mentioned so far, and you've said this, and I just want to further highlight it as an oncologist referring patients to palliative medicine for help. I think one of the things that happens, and you just said it, we're focused on that CA125. We're focused on the treatment and prescribing the treatment and getting through the treatment and seeing the responses and that graph piece. And I think one of the things for me as a clinician that is why I'm actively seek to have my patients see palliative medicine is that having that separate space where the focus can be less the treatment and entirely these other things is very important. And so then, you know, that conversation about financial toxicity can be hard to have with your oncologist, because I think people don't want to sway our thinking. People want us to give the best treatment and not give the best treatment at the lowest cost. Or people don't want to tell us they're not eating as well because they don't want us to say, oh, you can't get treatment today because you have that symptom. And so I see those survival graphs, and I think sometimes, or I think what's happening in those cases is that there's early intervention for those symptoms because there's a safe space to say it without any associated anxiety about what those symptoms mean and what the implication of those symptoms mean. So I sometimes think that that palliative medicine visit in some ways is a therapy for the anxiety almost, because it's an opportunity to have those honest conversations without worrying what the impact might be on treatment planning, so to speak.
You are so right, Stephanie. You are
Yeah.
so right. We actually did a study when I was still at Virginia Commonwealth University. We interviewed 85 people being admitted to the cancer unit. And they're all, you have to be really sick to get admitted these days, in those days. And I had a fourth year medical student interview them all. And she said, it was about advanced directives. And she said, do you think it's important when you come in the hospital to have a discussion about advanced care planning? What would happen if you got sicker, like if you stopped breathing? Oh, yes. 90% of people said yes. And then follow-up question was, would you feel comfortable discussing this with the team that's admitting you that you've never met before? And 85% said, oh, of course, absolutely. And then she said, the next question, would you want to discuss this issue with your treating oncologist? No.
Yeah.
And what was that? No. And I'm sure she's texting, WTF to her friends because it didn't make sense. It seemed so paradoxical. But we did some drill down questions, and it's exactly what you said. If I have bad things happen to me, I want my treating oncologist to concentrate on treating my cancer. The second most common answer was, it would be too hard on my oncologist to have this discussion. So you folks out there are protecting us. Sometimes we have families trying to protect loved ones and loved ones protecting families. You'll have the family grab you outside the room and say, don't tell mom she has cancer. And then you go in at 7 o'clock in the evening and talk to mom, check our pain control. It's just, don't tell my family I have cancer. That works out okay in some cultures where the right not to know is as important as the right to know. But most of the time, you hope you can get people to say, what's the worst thing that could happen if you both agreed that mom is pretty sick, has a limited amount of time to live, and you wanted to create her legacy in a way that her kids and grandkids and grandbunnies would, know who she is. And Stephanie, I'm so into the oncologist mode. This is a graph I printed out for somebody on telemedicine yesterday. So he couldn't come into the office, but you can see that's a pretty good marker, down from 2,300 to 3 with a new drug. So it's so much easier to concentrate on that stuff than to say, well, tell me about all those bones that hurt. You'd expect with that amount of cancer shrinkage that his bones wouldn't hurt anymore. But in fact, he's got a fair number of damaged bones that they're going to hurt, and they're going to hurt for months, if not years. So we have to evolve a treatment strategy for that.
You mentioned advanced care planning, and it's a phrase we use. Can you expound a little bit on what all is part of advanced care planning, and why is it so important for everybody, not just cancer patients, for everybody actually to engage in a process of advanced care planning?
Yeah, it's a little bit like having car insurance. I mean, you don't want to sign up for car insurance after you've just ran your 63 Corvette into a tree, right? Advanced care planning is really what should happen to you? What are your wishes if you got sicker from any cause? Not just cancer, it's heart disease, it's mental illness, it's anything. Sometimes that comes down just to the really blunt questions. What would you want us to do if your heart stopped breathing, your heart stopped beating, or you stopped breathing? Would you want to be on a ventilator or not? That's probably not the first question you should ask. The first question you should ask is, so tell me who you are. Tell me what's important to you. Tell me what you're hoping for. So I get to know you as a person. And then, have you had any discussion about what might happen in the future if you got sicker, where you might need a living will or advance directive? And people say, well, what's a living will or advance directive? And well, it just tells us how you want us to proceed if you do get sicker. Because, you know, in this day and age, not everybody is cured of their cancer and everybody gets sick. I tell my own patients, it is so much easier to have these discussions at 2 o'clock on a Tuesday afternoon, sitting around the kitchen table, than it is at 4 o'clock in the morning in the emergency department, where if you lose your ability to speak and you're really sick, then your loved ones are guessing at what you want. Maybe if you just had a heart attack, you absolutely want to be resuscitated and you go to the ICU for 3 days and see if it works out. But if you're really dying from a slow process of cancer that's obstructed your intestines, or, you know, given you major blood clots that can't be fixed, maybe you would really want to just have a peaceful, natural death. We can't guess. I can't guess as a healthcare provider. It turns out that loved ones hate, for the most part, hate to see you go. And loved ones tend to be over aggressive compared to the person who actually has the symptoms and the cancer. And the only way you're going to fix that is having an advance directive. And it says, here's what I'd want to do if I was in a terminal vegetative state, you know, like a coma. Here's what I would want to do if my cancer was growing and couldn't be fixed. That I'd really like to be at home, comfortable, surrounded by my family and friends, have a peaceful, natural death with hospice workers helping me towards that end, rather than dying in the ICU. I do have a couple patients who've told me I want to die in the ICU on a ventilator with a brand new drug going into my system. That's not very many, but it is some. Most people, if you ask, they'll say, if I get really sick, I want to be home. As long as I have a safe home, I want to be safe at home with my loved ones. I want to be surrounded by things that I know and love, and just make it as peaceful and quiet as it can be. We can't guess that. Maryland is really easy, as are most states. You can just log on your state advanced directives, and every single state has a free form that you can fill out. You do not need to pass go. You do not need to pay $250 to a lawyer to do this. You can fill it out and have some witnesses sign it, and it's legally good. The other thing is, if you do that, it's really nice if you share it with us so we can have it in your chart. It doesn't do much good if it's, you know, in your safe deposit box. Again, those are discussions that nobody wants to have, but it's so much easier to have them by the light of day.
Yeah.
I did have one woman that I ran into a couple of months ago. I'd given a talk down at in Bethesda to an evening support group, and I was saying, well, most of us really want to have a planned good ending if it has to end. And you can use this work to use this time to create legacy. Like if you've got young kids, you can write out birthday cards, going off to college cards, having your first relationship card, having your first big breakup card, or even DVDing or even a phone message, if there's a reasonable chance you won't be there. So I had this woman that I had an intense talk with, her and her husband, after the support group meeting, and I hadn't heard from them in about 3 years, but she walked up to me on the street and said, "You know, do you remember that talk you gave down at Bethesda 3 years ago? And then we came up and talked to you." Vaguely. Uh, and she said, "Well, my husband and I really took that to heart. So we did all those things. We got our burial plots done. We revised our wills. We revised our living wills. So she knows what I want. I know what she wants. We've, made some videos for our kids who are now 3 years older. And luckily they're in a stage where they can really remember us. And I am so thankful that I have that done, because now my cancer is really growing and I just don't have the energy to do any of that stuff, but it's all done." And then she gave me a hug.
I think that leads to the next question a little bit, or to a question, like a lead-on question, getting things done. When should things be done? When should someone see palliative medicine? We've sort of talked about the benefits of it, but how does a patient know? Let's say a patient's doctor hasn't recommended a consult. How does a patient know whether they're appropriate for a referral to a palliative care specialist or not?
Well, the American Society of Clinical Oncology guidelines, based on multiple randomized trials, say that every patient with advanced or serious cancer should see a palliative care team within 8 weeks of diagnosis. That's not earthly possible. There just aren't enough of us. Cloning's still illegal here. And we're making about 275 new palliative care doctors and maybe another 200 nurse practitioners a year, but that's still not enough. I would say anybody who has symptoms that are hard to control. So you've gotten very good at managing nausea. We talked about adding olanzapine to a nausea regimen. Really, really works. So if they're undergoing chemotherapy and not having any problems, we don't need to see them. And you can always call us up and ask for advice about something like that. But when somebody develops intermittent bowel obstruction, somebody develops kidney blockage, somebody has bad neuropathy, somebody's having a really significant adjustment reaction, either anxiety or depression. Those are people that we can help you with. And it's not that you're not good at doing those things. I know you, and I'm quite good at doing those things. It's the time that it takes to do that. In my breast cancer practice, I will send some of my patients to see my palliative care colleagues because I don't have the time when I'm discussing their chemotherapy and side effects to go through all these other things that should be discussed, but I just can't do it in a visit.
Yeah, I think that's right. It is the time. Can we talk about a few other symptoms that I think are the common symptoms that folks talk about? Fatigue. Do you have any fatigue? And I get questions about things like, is drinking more coffee helping, or will drinking more coffee help me? Which obviously we have answers for, or there's medications, like I've had patients ask me for Ritalin and other things. So what actually works for fatigue?
What you need is the 2-hour energy shot, the 4-ounce size. I tried to convince the people who make 5-hour energy to do a randomized trial of placebo 5-hour energy versus regular 5-hour energy in cancer fatigue, and they never answered back to me. I wrote them and called them, they never answered back. I'm afraid they would find it was negative. People have been trying to find solutions to cancer-related fatigue for a long time, probably 40 years. Ever since cancer chemotherapy was invented, it's been making people tired because it beats your body up. There is no single one universal thing that helps. The one thing that works better than anything else, paradoxically, is exercise. So I ask patients, well, what do you do to exercise? Well, nothing. Okay, well, Coach Tom wants you to get your sorry butt out and walk for 20 minutes in the morning and walk for 20 minutes in the evening. I don't care how far you go. I just want you to walk, and then we'll work up on the intensity. Exercise seems to be the only thing that helps people with cancer-related fatigue. After that, we're really stretching. And I found during chemo and radiation, I needed to take a nap twice a day. My team found me with my nose down in the keyboard a couple of times at 11 o'clock. So I just figured at 10:30, I'm laying down for half an hour. And at 2:30 in the afternoon, I'm laying down for half an hour. Anybody who's getting pelvic radiation, you're gonna feel really tired starting about 2 weeks after and continuing about 4 weeks after you stop. So you just have to be prepared to take a nap in the afternoon. Doesn't matter what part of the body you're radiating, but particularly the pelvis, that's almost universal, even for Olympic athletes with a touch of cancer. Other things that might be helpful, I mean, caffeine is helpful for some people. Guarana, the South American herb, which is basically caffeine, seems to help people with radiation therapy related fatigue. It's the active ingredient in, I think, Monster energy drinks and a couple of others. So you can try it and see if it works. American ginseng has been tested in 2 big trials at the Mayo Clinic, comprising almost 400 patients. They went to the Wisconsin Herb Co-op, and not to get regular herb or cannabis, but to get American ginseng. And then they tested it versus placebo. And 4 500 milligram tablets a day seemed to help a little bit by 4 weeks and a little bit more by 8 weeks. It is not amphetamines that zoom you up like this. It's gonna maybe tilt your fatigue, tilt your energy a little bit up like this. Doesn't help with the mental part at all, but it does seem to help with the physical fatigue for some people. And the chance of getting side effects are really low. If you go to the Wisconsin Herb Co-op, you can buy a month's supply for $19.95 plus shipping. I'm not on retainer from them, nor am I, or from Energy Shot. You can try things like methylphenidate or Ritalin, or even amphetamines. It's probably not fixing anything that's causing the fatigue. What's causing the fatigue is we've triggered some reflexes in your body that make you feel like you have the flu. So you look at soluble tumor necrosis factor levels, there's 2A, and they're up. So your inflammatory proteins are up in your blood. So it makes you feel like you got the flu. And that's probably just a normal reaction to being beat up by chemo and radiation and surgery. Giving amphetamines doesn't help that at all. In a pinch, if it can really help. The studies that have been done, mostly at MD Anderson again, show that if your fatigue score is greater than 8, so if on a scale of 0 to 10, no fatigue to the worst possible fatigue, if it's 8, 9, or 10, those are the people who are going to get a benefit from it. So I give people 10 5 milligram Ritalin tablets, methylphenidate. And I say take 1 in the morning at 7 o'clock, 1 in the morning at 11 o'clock. We'll try it for 2 or 3 days. If it works, great, we'll continue it. Because you can tell in that first 48 hours with 85% accuracy whether it's going to help. Most people are, not so much, just made me jittery. But some people say, I felt like I had a new lease on life. I felt like I could stay awake during the day and then I could sleep at night. So I said, I give people 10 pills and say, let's try it for 3 days. If it works, great. If it doesn't, you can sell the others down at the local junior high school for quite a profit. So
Now you mentioned sleep, and it was a timely thing to comment on because while we were talking about fatigue, someone posted the question. I have trouble sleeping at night. I used to be a good sleeper, and now I can't sleep. And the question actually came with this person has tried Lunesta, for instance, and it didn't help.
Yeah.
But I do find, I'm going to expand the question because there's the I can't sleep and so I'm fatigued, and there's the I'm exhausted but I can't go to sleep, and then there's just the I can't sleep. So I feel like sleep is a big issue. So could you talk a little bit about sleep?
Yes. You want to figure out why the person isn't sleeping. Is it anxiety? Is it hot flashes? For me, it was just hot flashes. When my testosterone level hit zero, like people's estrogen levels hit zero, I just didn't feel normal at all. And I had complete and total insomnia. And then you added the hot flashes on top of that, and it was miserable night after miserable night after miserable night. You want to decide, is it trouble falling asleep or is it trouble staying asleep? And if it's trouble staying asleep, do you have early morning awakening, like at 4 o'clock, 5 o'clock in the morning, that fits with depression? So you want to screen for depression. Are you depressed? Do you feel like you're depressed most of the time? And sometimes you can find a drug like Remeron or mirtazapine, which is a really good antidepressant and helps put people to sleep at night. So you can kill two crabs with one stone. If it's, I just can't fall asleep, but I'm not depressed. You want to practice good sleep hygiene. If you can't sleep for 20 minutes, get your butt out of bed, go read a book, have some warm milk, maybe with a shot of brandy. Do whatever you would normally do to try to get back to sleep, but don't toss and turn for hours and hours at a time. The sleep cognitive behavioral people will tell you sleep hygiene is important. If you get to sleep, great. If you don't, get up out of bed, do something else. If you start to feel sleepy, then try it again. There are lots of medicines that actually work for sleep. The National Comprehensive Cancer Center Network lists a whole bunch of them that actually help with sleep. Ambien or Zolpidem commonly works for some people. You can tell in 2 or 3 days if it's going to help. If 5 milligrams doesn't help, try 10. If 10 doesn't help, it's probably not going to help at all. It puts you to sleep. It may only keep you asleep for a couple of hours, but if you get 4 hours of REM sleep, then you're much better off than none. Trazodone is commonly used. It's an antidepressant, 50 milligrams at night or 100 milligrams at night. Sometimes leaves people with a hungover feeling. Lunesta, or the fancier chemical name for it, works for some people really, really well. Melatonin works a little bit for some people. I've never had much success with it, either personally or with my patients. Some of the longer acting benzodiazepines, like temazepam or Restoril, they can work and put you to sleep for maybe 6 hours. People worry about, well, am I going to get addicted to a sleep medicine? Am I going to get addicted to opioids? And my wife, the geneticist, would say, if you've gotten past 40 without getting addicted to something, chances are really, really, really slim, like this slim, that you're going to get addicted to either pain medicines or sleep medicines. That said, if you've required Ambien 10 milligrams or 12.5 milligrams CR to sleep for a year, and you've taken it every year, do not stop it cold turkey. You have to taper it off. Otherwise, you're going to have a couple of really uncomfortable nights or weeks with being wide awake, having dreams, possibly even hallucinations, just as your brain recovers from having those receptors occupied. Try to get up and do stuff during the day. Try not to nap during the day if you can, except if you can't possibly do it. Everybody will tell you that if you have a good night's sleep, the rest of the world looks much better.
Now, you sort of mentioned in passing and kept going, but use of marijuana for symptom management. And I say marijuana, and then I actually will also say THC and CBD because I have, as I've become more aware, realized that these are really three different things. And so could you talk a little bit about use of marijuana, CBD, THC for sleep, anxiety, pain, neuropathy? I mean, I've seen it used in so many different arenas for symptom management.
Yeah, it's complicated. If you saw the New York Times Magazine, it had a CBD gummy on the front and said, can CBD really cure all these things? And it had a list of about 30 symptoms. And the answer is, we really have no friggin' idea. The one good randomized control trial I could see for CBD when I made up a lecture a month or two ago was about social anxiety and speaking. And the randomized trial, so half of the, you can't stand up in front of an audience and speak. Half of them got 600 milligrams of CBD, which is a whole bunch of gummy bears. That's a whopping dose. And the other group got placebo, and it really did help people lose their social phobia. That's about the only randomized trial that's out there for CBD. It's not a great cannabis. Let's stick with it. CBD, I don't know if it works or not. I tried it for my lungs, it didn't help. I've tried it for my arthritis, it doesn't help. It may be that stronger strengths than you can get over the counter, like at a head shop or apothecary, they may work. I've had some people who've had neuropathic pain, it seemed to help them. But let's leave CBD aside. THC does help some people. It's not a great drug for anything, but it's an okay drug for a whole bunch of things. When I was an intern back in 1979 at the hospital that shall remain nameless, the nurses would send our leukemia patients up to the roof with a joint to smoke to come back because we had no other good anti-nausea medicines. So it's not the best anti-nausea medicine right now. Probably olanzapine is the best anti-nausea medicine. And olanzapine, again, is probably the one medicine I choose when I'm trying to stimulate somebody's appetite rather than going straight to cannabis. If you look at the randomized controlled trials, they're all flawed in the United States because they're using a 1964 strain of cannabis, which is way different than what's available in any apothecary shop right now. Sativex and the others have all blossomed out. If you look at the real world experience in Minnesota, where if you signed up for medical cannabis, don't you know, you had to provide some data to the Medical Cannabis Commission. So you would send in forms. And it really did seem to help with anxiety, with pain, with appetite, with nausea, with depression. That most people who started with pain scores of 9, a couple months later, they were down in the 3-4 range. Does it actually reduce pain? We don't know. Does it dissociate you from the pain so the pain doesn't bother you? Possibly. I frankly don't care. If it helps your pain, I'm all for it. So I become a certified, a certifier, so I can certify patients that I have a legitimate relationship with, and I'll tell them to go to the apothecary and make sure you get sour gorilla, and I want you to smoke 2 bowlfuls of sour gorilla at night. Just teasing. That's what one of my patients did that, and she had 2 bowlfuls of sour gorilla at night with her neuropathy, and she got the best night's sleep she'd had in years. You have to start slow. The commercially available product is dronabinol or Marinol. It's 2.5 milligrams of THC or 5 milligrams of THC. That's pretty low dose. So if you're going to start with something, start at that low dose. So ask for something where you might get a tincture that has 3 milligrams of THC per dropper full. Or if it's a gummy, it's a 10 milligram gummy, cut it into fourths and start with 1/4 of a gummy. For those of you who have had experience with cannabis in the past, today's products for inhalants are incredibly stronger than what you might have grown up with, maybe 25 times more potent. So you have to be really careful about not taking too much all at once. They're really quick. You have receptors for cannabinoids in your lungs and in your brain. They're there to help modulate your immune system and a whole bunch of other things. They really do work. Start really low. If you're starting with a gummy, start with 2.5 or 5. Remember that a gummy or an edible is going to take about an hour to take effect. So don't take a dose now and then 15 minutes say, I thought I'd be listening to Pink Floyd by now, and here I'm not. And so I'm going to take another one and another one. And I've had people do that and end up getting really stoned for hours at a time because it takes the gummies a longer time to work. So give it at least an hour. The biggest side effects that we see in people who are never or former users, anxiety and heart palpitations. So expect that, find a quiet spot, be surrounded by people that you know and love. Don't sit out in a parking lot someplace with, trucks whizzing by. Be in a safe spot in case you get anxiety or palpitations. They'll pass, and most people learn to live with them pretty easily, but not everybody does.
Can we go back to neuropathy for 1 second? And there's two things that come up. One, the use of acupuncture, and that's a little bit pain too, it comes up. And then the second is scrambler therapy. And I recently had a patient tell me something very interesting, which is she went and bought one of the massage vibrators that you can get at the specialty shops in the mall. And I'm blanking on the name of the specialty shop, of course. But she says she used this on her feet, and you rest your feet on it and it does that shaking motion. And she says it helped her neuropathy tremendously. And I sort of went, is that because it's potentially linked to the scrambler? Is that something you've heard other patients say? And what about these two things, scrambler therapy and acupuncture for neuropathy? And then I promised you we'd end on time. So I apologize in advance because I'm not going to keep my promise. But last two questions, I promise.
We just rewrote the national guidelines on management of chemotherapy-induced peripheral neuropathy. It's a major problem. It really sucks if you have it. I mean, again, it just puts you right back into reminding you that you had cancer. Couple of things that are really interesting: stretching the skin, exercise, doing this. That may be stimulating those damaged nerves and sending a normal cooling signal up the pathway to the centralized area in the brain where it's being felt. So exercise or massage may help. The menthol, putting it on the outside here or on the hands, that binds to receptors there. It sends a cooling message up to the brain that might help. It's hard to do acupuncture sham trials or placebo-controlled trials, but our committee came to the same conclusion that every other committee has come to say that the data simply are not sufficient to say that acupuncture works. It's got to be somewhat dependent on the skill of the acupuncturist, the type of neuropathy the person has. In my experience, pain is much easier to treat than numbness or tingling. I think it's easier to isolate those nerves. Cymbalta, for instance, duloxetine, only helps with the pain. I don't think it helps with the numbness or tingling at all. And that's sometimes what people are left with, which is just as bothersome. We do scrambler therapy here. Unfortunately, the waiting list is really long. We just published a trial with us in Mayo Clinic, and we saw about a 60% reduction in pain, 40 to 50% reduction in numbness and tingling. It's like putting EKG electrodes on your skin and then being bitten by electrical ants. And it's feeding in non-pain information up to this part of your brain that's oversensitized to this constant barrage of nerves. The other thing that I'm really excited about working with Chao Xing-Ye in the School of Nursing is ear point acupressure, auricular point acupressure. So that she takes these little tiny flower seeds, they look like mustard seeds almost, but smaller, on a piece of sticky tape, and then you pulse them. If they're in the right spot, you pulse them for 3 minutes, 3 times a day, and it really seems to help chemo-induced neuropathy. We saw pain scores go down like that. numbness scores go down like that, tingling scores go down like that, and stiffness go down as well. So we're just going to start, hopefully in January, a randomized sham-controlled trial to see whether it was really the acupressure or was it the fact that Chow-Sing is just so incredibly nice, and there's a placebo effect to seeing a really nice PhD nurse who really seems to know what she's doing. She did it to me during chemo and radiation, and I swear it helped me a significant amount. So stay tuned to ear acupressure or auricular point acupressure.
That's fabulous. I wish we could keep going. But I'm gonna get cut off by a whole bunch of things, and I know you have other things to get onto. I can't thank you enough. I could ask you questions and listen for hours, and I know my patients are always incredibly grateful when I send them to see you, and have always found it very helpful, which I hope everyone listening takes not only as a commentary on Dr. Smith, which it 100% is. I think over the last hour, you have seen how fabulous he is. I also think for those of you who are not local and don't have the opportunity of seeing Dr. Smith specifically, it is a commentary on the role of palliative medicine and the possibilities and the opportunities and all the different options that maybe we as oncologists don't always think of right off the top of our head. And so for those of you who are not right here in Baltimore and who aren't patients of ours here and who are seeking help, please know that this is not just reflective of our institution, but many. So palliative medicine, as you've learned today, I hope has a key role in the management of cancer. I hope you've gotten some of your questions answered. And again, thank you so much, Dr. Smith. It has been a real pleasure for me. And I know for everybody else who's been commenting as we've been going on our Facebook, there are many smiley faces and thank yous and appreciations and hopes that it will be posted so other people who couldn't be on in the middle of the day will be able to gain benefit. So thank you, everybody. And next month, just a short little preview, next month we will be doing our webinar on granulosa cell tumors, and it's going to have a little twist. So granulosa cell tumors and also advocacy for rare tumor awareness and research. So that will be on a Thursday evening with Dr. Fader and one of our patient survivors, Kim. So I'll see everybody next month. Thank you again. Bye.
Thank you.